Thank you, Mike, for such a kind introduction. And I would like to thank Prostate Cancer International and Cancer Support Community for inviting me to give a talk on this topic. Most of you guys have heard my prior talks, mostly on focal therapy of prostate cancer, which is the major part of my prostate cancer practice. A smaller proportion is managing patients with advanced prostate cancer and recurrent prostate cancer. Um, I don't have any disclosures for this talk. And as you guys, most of you guys are aware, we have a multidisciplinary prostate cancer care program at UC since I started here 4 years ago. And we have created multiple branches of our prostate cancer program, including trials, survivorship, multidisciplinary clinic, focal therapy, and advanced prostate cancer is something which I'm really passionate about. Um, so these are the objectives of my talk, and we'll try to address. Mike, thanks a lot for giving me an overview of what you exactly wanted me to present, and I'm hoping this satisfy the questions you asked. So we're going to start with the case study, and this population is relatively rare, but this is what exactly I thought I was asked to address the management about. So John is a 75-year-old male with good performance status and prior history of prostate cancer. Looking back into his history, he was first diagnosed at age of 65, which is kind of median age for prostate cancer diagnosis. But his PSA was very high. It was 25 nanogram per ml. And patient underwent a biopsy, which showed Gleason score of 8 or grade group 4 disease. And that puts him in a very high risk category. And he chose to undergo robotic radical prostatectomy after his staging workup did not show any evidence of cancer outside prostate. His path came back as Gleason 8, same as biopsy. His stage was T3A, which means there was evidence of prostate cancer just outside the capsule of prostate. But fortunately for him, his lymph nodes were negative. And his post-op PSA at 3 months was 0, undetectable. So things were going well until year 2, his PSA came back, and then it rose to 0.2 nanogram per ml. And why is 0.2 nanogram per ml important? This is the definition where we say, yes, this is likely cancer and needs treatment. It's a definition, it's called biochemical recurrence of prostate cancer. He underwent again metastatic workup at this point, which involved CT scan and bone scan, did not show any evidence of cancer. So he underwent radiation therapy in the prostatic bed along with a short course of hormones, androgen-deprivation therapy, and he had great PSA response. And things continued to do well for him until he was 9 years out of the surgery. And his PSA continued to rise, and now in 2021, his PSA is 1.5 nanogram per ml. So very high for a patient who has undergone surgery followed by radiation therapy. So he got another set of scans, a CT scan of his belly and a bone scan to look at any evidence of cancer in the belly and the bones. It was negative again. So this is a scenario which is where the management is not very well defined, and what's the next best step? And that's what the answer we're going to try to find today. So before we jump into the workup and management, let's discuss a couple of definitions for people who are not very clear what I meant biochemical recurrence. So biochemical recurrent cancer is actually a cancer which is detected only by presence of PSA in the blood. Typically, patients who have surgery, their PSA should be 0. Or patients who have radiation therapy, their PSA should be very low. If the PSA is rising and there's no other evidence of cancer, on any of the scans, that is called biochemical recurrence of prostate cancer. And since the cancer is not visible, it's not big enough to be even seen on the scan, it's not going to cause any symptoms. So these patients are asymptomatic. The other definition to remember is metastatic prostate cancer. And metastatic prostate cancer is a cancer which has spread to other parts of the body. And it's obvious. You can find it either by symptoms, or you can find it on the CT scans and bone scans to involving lymph nodes, to involve bones, to involve liver, lungs, and other organs, right? So there are two types of cancers which are not located in the prostate. One is biochemical recurrence, and other is obviously metastatic cancer. And then there's a middle category called micrometastatic, which is essentially biochemical recurrence, but the cancer is so small that the scans would not find them. So John got a CT scan and bone scan, and no evidence of cancer was seen. But he has a PSA, which is 1.5 nanogram per ml. So what does that tell us? That there is cancer somewhere. Just our current imaging with CT and bone scan is not good enough to pick that cancer. And that's why there's a role for something called next generational imaging. In most cancers, you must have heard something called PET scan. It is a very sensitive test to detect cancer which has spread to other parts of the body. But the standard PET scan, which we use in bladder cancer or lung cancer or other cancers, has been shown to have low detection rate in prostate cancer. And since we need to determine if there's evidence of cancer in our organs, as there are implications of treatment, there are different treatment if you have metastatic prostate cancer versus if you have only biochemically recurrent prostate cancer, right? So it's important. And so that's where the next set of imaging comes into picture, okay? There are several tests which are approved now. 6-7 years later, we didn't have any test. You get CT scan and bone scan, and that's it. And then you use your clinical judgment to decide what's the next step. But now we have several tests. I'm listing some of the more commonly heard tests and tests which are more commonly available. The most common one is Fluciclovine test, and it's widely available. This is a test which looks for an amino acid transporter in the prostate cancer cells, and it's supposed to tell if there's an evidence of cancer in the area where the prostate was. It's called prostatic bed, or anywhere in the lymph nodes, bones, or other organs of the body, right? This test is approved by Medicare, widely available. The indication for the approval is recurrent prostate cancer. It's not approved if patients had no prior treatment. You have to have prior treatment to get this test approved, okay? This test has it's better than regular scans and better than regular bone scan, but it's not perfect. It misses still a great deal of cancer, and also has a lot of false positives. Like it'll say that potentially there's an uptick there, so there's a cancer there, but you would biopsy them and it would come back negative, right? So not a perfect test. The two tests which has recently been in news, as they've been recently been approved, are the PSMA tests, right? PSMA is a marker on the prostate cancer cells. It's a protein which is on the cell membrane of the prostate cancer cells. So these tests detect that marker. So wherever there will be a prostate cancer cell, whether it's in the prostate, whether it is in the liver, whether it is in the bone, whether it is in the lymph node, these markers will detect them. And there are two tests which have been approved with PSMA. One is called 68 gallium PSMA, and other is called 18 fluoride DCF-PYL. This is more recently approved in May of this year. Gallium PSMA was approved in December last year. Both these tests have been shown to have better detection than the fluciclovine test, which is widely available. And fluciclovine is better than 11C choline, so nobody talks about this test anymore. But the PSMA tests have been shown to be better and got recent FDA approval. So this is a study comparing the PSMA PET, the gallium PET, to the fluciclovine. And if you see, the pink bars are from PSMA. And overall, it's very high detection, 56% versus 26%. And almost in most scenarios, PSMA works better than fluciclovine PET. Only in the prostate bed, fluciclovine PET is comparable to the PSMA PET. This study was done at UCLA using gallium PSMA. Now, why is gallium PSMA is not the correct answer for a lot of patients? Because the gallium radioactive marker is very unstable. Its half-life is only 68 minutes. So the facility need to have a cyclotron on the site, and they need to prepare this chemical 3 times a day to scan their patients. You can't prepare it 2 hours away and transport. And that's why this test never became widely available in the United States. However, the PYL marker, which was recently approved in May, can be prepared more easily and in larger quantities and has a half-life of 110 minutes. So you can potentially prepare it in Columbus and can supply in 2-hour radius easily for the patients. So it's likely to be more widely available in next 6-7 months. Currently, it's not as widely available because it just got approved in May. Both gallium PSMA and PYL PSMA tests do not have like widely available insurance approval. You can get limited approval from Medicare, but the commercial insurances do not approve these tests yet. Okay, so Mr. John got this test done, right? There are 2 scenarios. Either you found cancer outside, he doesn't have prostate, he has radiation in that treatment. Either you found prostate cancer outside the prostate area into the lymph nodes or the bones, or you didn't. So if you found prostate cancer outside, that's a metastatic prostate cancer, and the management is different. And this talk is not going to cover that management. We are sticking with scans were done and no cancer was found. So what's the next step? Genetic testing. Normally, there are 2 sorts of genetic testing we do for prostate cancer patients. One is called germline testing, and it is conducted on either blood or saliva, and it identifies the inherited genetic mutations present in every cell of the body. So these tests will look at your DNA which you were born with, and if you were born with a mutation which puts you at a higher risk of prostate cancer or not. These are the same mutations which family members will inherit among themselves and will share. So if a patient is positive, there is some chance that his siblings or his offspring will be positive, and then they need to be tested for that mutation. And it's important because some of the advanced prostate cancer therapies, you can become only eligible if you are positive for certain mutations, like, and we're going to go over next in next slide. So NCCN, National Cancer Center, recommends germline testing to be done in patients who have high risk, very high risk, regional or metastatic prostate cancer. So John, when he was first diagnosed, had very high risk prostate cancer. So if he would be seen in, for example, my practice, he already would have germline testing, right? And these are the genes you are born with, so they don't change with time. Even if your cancer comes back, this is the DNA you were born with. So you would not need repeat testing. But if he was not tested before, he needs to be tested now because he had very high risk prostate cancer. And the other categories where you would check germline is certain sections of Jewish ancestry and patients who have high risk germline mutations, BRCA1, BRCA2, the same mutations which are present in patients with familial breast cancer. The other syndrome is called Lynch syndrome. This syndrome puts patient at high risk of several other cancers. So if there's a family history of these cancer syndromes, then patients with prostate cancer should be checked for germline mutations. And positive family history of prostate cancer. And if some patient with prostate cancer has also brother or father with prostate cancer less than 60 years old, then it's indicated to check germline testing in those patients. Or if they have several cancer in the family without any inherited syndrome, it is still advisable to do germline testing. The second sort of testing is called somatic testing. And somatic testing is what I think most patients are more familiar with. All the tests like Oncotype, Decipher, Prolaris, all the testing done on the biopsy tissue when patients are diagnosed, they're called somatic testing. And it is conducted on either the biopsy tissue or the circulating tumor DNA in the blood, which is called liquid biopsy. So this kind of testing tests for genetic mutations that exist only in the tumor. So you are born with some mutations which put you at a higher risk of prostate cancer, but as you get older, there is more environmental damage, there's more toxic damage, there is smoking, age, all those things put you at higher risk of acquiring further mutations in your genetic makeup. And somatic testing will check for both, right? It's what's the final product after you've lived 50, 60, 70 years? What's the final product of your DNA in the prostate cancer cell, right? And this testing has prognostic value because, it'll tell you how bad your prostate mutations are. And if you have bad prostate mutations, you have higher risk of failing treatments, higher risk of cancer coming back. Same like genetic mutations, there are some somatic mutations which open up your door for further treatments. Some treatments work only on certain mutations like PARP inhibitors. PARP inhibitors work in patients who have mutations in the repair mechanism of the DNA, right? So finding those mutations are important because then you might have extra line of treatments down the line. So this patient, John, should have gotten both genetic mutation at the time of diagnosis, and he should have gotten somatic mutation. If not at the time of diagnosis, it's his time to get it now because now his cancer has come back. So NCCN recommends somatic mutation in patients who present with cancer outside their prostate or their PSA comes back, like in this biochemical recurrent prostate cancer. But now in his case, since there's no tissue to do the mutations, you would do a liquid biopsy. So this patient should have gotten liquid biopsy. And the tumor should be evaluated for things called microsatellite instability or mutations in the DNA for like repair mechanism. Like their DNA acquires damage, but now the DNA does not have genes to repair, right? And those patients are at a higher risk of getting bad prostate cancer. So John got that testing done, and fortunately for him, everything was negative. He did not have any evidence of high-risk mutations, but we still are dealing with a situation where his PSA is still back. So there is cancer somewhere. And now he has an option to start something called androgen deprivation therapy, or in layman terms, hormone therapy for prostate cancer. So before we jump into what androgen deprivation therapy is, let's talk about what is androgen production. Androgen is the male hormone, right? This is the hormone which gives males ability to have erections, libido, energy, ability to build muscles, and if and it also feeds prostate, both prostate and prostate cancer. So if you want to starve prostate cancer, control prostate cancer, uh, then you need to take that testosterone and androgens out of the body, right? So androgens production starts in the brain, in a part of the brain called pituitary, which releases something called LH, luteinizing hormone, which goes to then testicles and stimulate testicles to produce testosterone. Okay, testosterone is the most potent androgen. And then adrenal glands, which are small glands above the kidney, also produce some androgens, but they are only a minor component. Most of the androgens are coming from the testicles through testosterone, right? So what is hormone therapy for prostate cancer, or androgen deprivation therapy, which is more scientific term? It is a therapy which reduces androgen production by testicles. So it reduces the testosterone production by testicle, or the androgen production is ongoing, but it blocks the action of androgen, or the third way to do is to block androgen production throughout the body, both adrenal glands and testicles. So a quick way to achieve deprivation of androgen is through orchiectomy. Orchiectomy means removing the testicle. It is called surgical castration. The advantage is it's a one-time procedure. It's one of the most cost-effective way of doing the androgen deprivation therapy. The disadvantage is it's a surgery. It has to be done under anesthesia. And even though it's not a major surgery, but it's still invasive more than other aspects, other methods to achieve androgen deprivation. The second, which is actually a more common way to achieve androgen deprivation therapy, is through LH-RH agonist and antagonist. So if you remember from the prior photograph, this hormone LH-RH is produced by the brain and activates the pituitary, which then activates prostate, right? So if you can block this, then everything shuts down. It would not produce testosterone, and that's what the mechanism is for LH-RH agonist. These are injections, and the most common one are Lupron and Eligard, and a lot of people who deal with prostate cancer gets one of those two injections. They are non-invasive. That's the best part about them, but they're costly in long term. Insurance covers them really well, so most patients won't pay anything much out of the pocket, but they are costly treatment in long term. And the effect on prostate cancer is similar whether you get a shot or whether you get orchiectomy done. While these are just shots, tiny shots in your skin, they cause a lot of side effects. And anything which is stimulated by testosterone is now going to be blocked, is now going to be reduced, right? So the first thing is loss of interest in sex, losing erections. It puts men through a kind of male menopause. So men would have hot flashes. The bones will get weaker with time, and men would need vitamin D, calcium, and other ways to maintain their bone density so that they can avoid fractures in the bones, right? We need hormones to build up muscle. So now we're countering those hormones, so there will be loss of muscle mass. And it also changes how your metabolism works, right? It makes lipids metabolism go haywire. Patients have a higher risk of developing diabetes. They gain weight. And then there are psychological issues like mood swings and always depressed, and they get fatigue. And some men will also have growth in their breast tissue. So a lot of side effects. And that's why we always take it very seriously if the patient needs to be started on androgen deprivation therapy or not, right? This treatment is not without any side effects. Um, so this graph tells you about the natural history of prostate cancer, right? And patients get diagnosed with prostate cancer, their PSA is rising, they get prostatectomy or surgery, and or radiation therapy, or their PSA comes down. Then the PSA rises back again, right? This is the definition of biochemical recurrence. So the PSA is coming back, but there's no evidence of cancer outside prostate. And what's the next step at that point? And eventually, when the PSA rises very high, patient gets started on androgen deprivation therapy, which brings the PSA down, but eventually the cancer will break free and it will come back, and patient will need further lines of treatment. So John has a scenario where he has gotten 2 lines of local treatment. He had undergone surgery. He has undergone radiation. So there's nothing much we can offer now for his prostate, but his PSA is coming back. We got CT scan done. We got the next generation imaging done, and there was no evidence of cancer. His genetic testing was fortunately negative. We have still not localized the location of cancer where it is. And that leads to the crux of this discussion about how should you manage that? Should we just keep an eye on things for now and let PSA rise higher, or have patient develop signs of metastatic disease, or have patient get cancer in their bones or lymph node before we start them on something? So we're going to go over what NCCN talks about in their guidelines about how these patients should be managed, right? For men who are either not receiving salvage therapy, which means they underwent prostatectomy, PSA came back, and for some reason they are either denying radiation therapy, or they are not good candidate for radiation therapy, or they had radiation therapy, PSA came back, and they are either not candidates of surgery, not candidates for HIFU cryoablation, or they got both treatments and PSA come back. Regardless, now we're dealing with a situation where there's a PSA but no obvious evidence of cancer. The most important point here is to decide when to start androgen deprivation therapy. Okay, considering all the side effects of these treatments, the longer you wait, the patients will have more years of better quality of life. But by delaying the treatment, are we compromising their survival? Are we making them live shorter? Are we giving them quality years, but are we making them live shorter versus start them now, impair their quality of life, but make them live longer? And there are several factors which go into the clinical judgment to decide when to start these. PSA velocity, or PSA doubling time, is one of the most important factor. If the PSA doubling time, and different papers have highlighted different PSA doubling time, but PSA doubling time means the amount of time it takes for your PSA to double from 1 to 2, from 2 to 4, 4 to 8, right? And the studies have shown that shorter the PSA doubling time, the worse the prognosis. So if the PSA doubling time is less than 10 months, I would be more worried and start John on androgen deprivation therapy. But if PSA doubling time is greater than 12 months, then I know his cancer is not very progressive. It is slowly growing. So I have a lot more time to control this cancer. So I would probably not start him on androgen deprivation therapy. The other factor which dictates management is patient anxiety. There are certain amount of patients who would want their cancer to be treated actively, regardless of how slow growing or how minimal in quantity the cancer is, right? So if patient is very anxious, that would be something which will help in deciding the timing of androgen deprivation therapy. The other factor which dictates its comorbidities. If patients are very sick to begin with and they have limited life expectancy, does it really help to start them on treatment for a cancer which is slow growing? Um, and finally, the grade and stage at the time of definite diagnosis. Studies have shown that if the cancer was pretty bad to begin with and a patient underwent surgery, radiation therapy, then the odds of getting metastatic prostate cancer after the biochemical recurrence are higher. So those patients probably need to be started on treatment earlier than later. So there are studies which have evaluated this question in more depth. There is a study from a capture database. It's a big database managed at UCSF. And they looked at 2,000 men who had scenario like John. The cancer came back, PSA was there, but no evidence of cancer seen on the scans. And they evaluated immediately starting them on ADT once the cancer came back, or waiting more than 2 years, or until they were able to see an obvious evidence of cancer on the scans, right? So that's deferred treatment versus immediate treatment. In their analysis, they did not see any significant advantage of starting patients early on ADT. Another study, again, this is again a retrospective study, it's not a clinical trial, in 5,800 men showed similar results. However, in a subset of patients where the PSA doubling time was less than 9 months. So in less than 9 months, the PSA was doubling from 2 to 4, 4 to 8, 8 to 16. They showed that starting ADT early improved survival, but probably not for all comers. There has been a phase 3 trial done for these patients. Now this is clinical trial, more data prospectively and better quality data. It was done in a smaller cohort, 293 men, and they were divided into 2 groups. One group got immediate treatment, other group got delayed treatment 2 years later, or after that development of obvious metastatic disease. What they found was the immediate group lived longer. At 5 years, 91% of the immediate group were still alive, while only 86.4%. So this study actually showed good quality evidence that starting these patients early after the PSA comes back is better than waiting 2 years or more after the PSA comes back. As expected, the quality of life was worse in patients who got immediate treatment at 6 and 12 months. But down the line, 3-4 years later, since everybody is on hormone therapy, the quality of life was comparable between 2 groups. But again, this is the group which got started early, so their quality of life was worse in the first year. The other question which needs an answer is, and it's still, as urologists, we have not figured it out, should we continue them on ADT every 3 months or whatever shot they're getting, or can we give them intermittent? Give patient a shot, a 3-month shot, but then wait another 3 months and start them on the 6 month, give them a shot 6 to 9 months later. So letting that PSA goes down to 0 and have it come back a little bit and then give the shot, have it come back a little bit and then give the shot. So this is called intermittent ADT versus a continuous ADT. Patient gets shot at regular interval. Whatever the interval is, 3 months, 6 months, they get regular shots to keep the PSA really, really low all the time. Does it impact if we let the PSA come back and bring it down? And a study has evaluated that, and they found that intermittent therapy was not inferior to continuous therapy. So patients did not live shorter by doing intermittent therapy. And quality of life was better with intermittent therapy also. However, in a subset of these patients, they found that patients with Gleason grade group 4 or Gleason grade group 5, which John falls into this category, patient had longer survival in continuous arm. So if you have Gleason 8, 9, 10 prostate cancer, or you have positive lymph nodes, or you have some bad pathology, then probably staying on continuous ADT might be better. However, this is a subset analysis. This is not the whole paper. The whole paper was if you use all comers into two categories, intermittent is not worse than continuous therapy and has better side effect profile. So this was my talk, and thank you so much again, and I'll take questions now.